Hi everybody. This week we are going to be talking about the right to die. Okay, I'll give you an outline. First I'll give you some context, and then in the Rachel's article you can distinguish, if you read it carefully, three different arguments. One about the kind of being more humane, one about deciding, well, I'll call it something short and simple, irrelevant criteria, and third, the difference between killing versus letting die. Okay? And then an objection that Rachel's considers. Okay. So first, a little bit of context. Let me give you some definitions. Okay. The first word to define is this one, euthanasia. Okay? Euthanasia comes from the Greek. It means good. That's the eu prefix. Okay? From Greek, the eu prefix, and death, which is thanatos. Okay? Also from Greek. Okay? Thanatos, by the way, trivia for you people who watch those Marvel movies, the supervillain Thanos, that name also comes from this root, meaning death. And I think it's actually a diminutive or short form for athanatos, which means without death, or which means immortal or without death. Anyway, that's where that supervillain's name comes from. Okay, so that's what euthanasia means. There are a couple of relevant distinctions here, though. One is between passive versus active euthanasia. So passive euthanasia is, and then active euthanasia. Passive euthanasia is letting someone die for merciful reasons. In other words, for the sake of, for the sake of the person dying. Like something is going so badly for this person, so much pain, irreversible illness, they're going to die soon anyway, that we might consider passive euthanasia. And that might take the form of, for example, not doing CPR on someone whose heart stops, or not giving antibiotics for someone who has an infection like a pneumonia. Okay, that's a way of letting someone die without you actually killing them. It's still the infection that kills him. It's still the heart attack that kills him. You just let him die by not rescuing him from those things. All right. In contrast is active euthanasia. And here you have killing. Okay, but again, if it's going to be euthanasia, it's killing for merciful reasons. Again, for the sake of the person dying. Okay, and for example, injecting a lot of morphine, okay, or these days there's a designer drug, fentanyl, which is like 1,000 or more times more potent than morphine, so you could do it with fentanyl too. And if you have too much morphine or fentanyl, that slows the drive to breathe, to respire, and so you basically stop breathing and die. You feel really good before that happens because you get a ton of morphine or fentanyl, and then you die. All right? So an active euthanasia, in principle, is done for the same reasons as passive euthanasia. Someone has an incurable illness, they're in a lot of pain, the pain will never go away, they're going to die soon anyway, they're just kind of permanently suffering and in agony, okay? All right, so that's passive euthanasia, active euthanasia. And then distinguished from all of those is what's sometimes called physician assistance in dying, or sometimes also called physician-assisted suicide. When I was growing up as an undergrad and in grad school, we used this phrase, physician-assisted suicide, or sometimes PAS. These days, they don't like to use the word suicide because it has this connotation of someone who is only temporarily depressed but will get better. And so people who are advocates for this, for physician assistance in dying, like to use the word dying instead of suicide. Okay? And you'll sometimes see this abbreviated, PAD, like that. Okay, so what is the difference between PAD, aka physician assistance in dying, aka physician assisted suicide, aka PAS? What is the difference between that and these others? Well, it's, in this one, the physician or really any healthcare provider, but the physician provides the patient with lethal drugs, okay, which the patient takes him or herself. All right. So the idea is the patient still, if it's going to be for merciful reasons, the patient still has, some terminal illness, is in a lot of pain, it's never going to get any better, et cetera, and asks the doctor, hey doc, can you give me a bunch of like some kind of opioid pills? You just give me the pills. You don't have to push anything into my system. You don't have to kill me. Just give me the pills and I will take them myself at a time of my choosing. All right? So that's physician assistance in dying. Okay. We can also distinguish something related to consent. And this actually distinction is not going to be that important for what we talk about this week, because we're only going to talk about one kind of euthanasia. So, and that's voluntary. Voluntary means with consent. Okay? But in principle, you can also have involuntary euthanasia. And you could also have, active or passive. Involuntary would be someone actively dissented, but you did it anyway. So, for example, someone says, no, I don't want that, but you just push the fentanyl anyway, saying, oh, no, it'll be better for you to die. Okay, that would be involuntary. Dissented, or another category here is, or could have consented, but was never asked. Okay? So the doctor just pushes the morphine without even asking first, and the guy is like totally awake and lucid and with it. That would also count as involuntary. And those are also distinguished from what's sometimes called non-voluntary. Non-voluntary, so my Apple machine doesn't like this non-word, non-voluntary. Okay? Non-voluntary is when you do this to someone who's unable to consent. For example, in a coma. So this person in a coma, for example, has never said whether he or she wants euthanasia, but you see him in the coma now and you just push the fentanyl. That's non-voluntary euthanasia. All right. Just about everyone believes that in almost all cases, involuntary and non-voluntary euthanasia are terribly wrong. We will not be talking about that. We are going to focus only on voluntary. Voluntary euthanasia, both passive and active, and also physician assistance in dying. Okay? When the patient, him or herself, requests the drugs, requests to be let die, requests to be killed, okay, and consents to it. All right. Okay, I guess another thing, maybe I should have said, let me go back a slide because I missed this. What I'm calling the right to die, let's use the phrase, the right to die, to include both active euthanasia and PAD, physician assistance in dying. We don't need to include passive euthanasia because of the thing that I was about to mention next, and then I forgot I should have mentioned this first, the right to die, okay? We don't need to include passive euthanasia because basically everyone thinks passive euthanasia is okay, and it's just widely seen and widely practiced in today's hospitals, okay? So let's talk a little bit about legal status. Okay, so passive euthanasia is legal everywhere, widely endorsed as perfectly fine, okay? And in fact, some of you who may have worked in hospitals or in nursing homes or in recovery centers or something, some of you who have medical experience may have experience with so-called DNR orders. DNR orders, DNR here stands for do not resuscitate. Let's see if I can spell this. Resuscitate. Nope. Let's see how Apple wants me to spell this. Okay, only one C. Okay, do not resuscitate orders, not presuppose, are examples of passive euthanasia. Okay, and a do not resuscitate order basically says something like, I'm really sick and ready to die. If I get a heart attack, don't do CPR. If maybe even, it might go further. Different DNR orders could include different details, but it could say something like, if I get pneumonia, don't give me antibiotics. etc. Okay, so a DNR order is typically done for someone, already at the end of life, late stage cancer, in a lot of pain, can't be cured, is going to die soon anyway, and you think in that situation, doing CPR to someone who's about to die anyway would be terrible because you're going to crack his ribs, you're going to, like do all these terrible things to him, and he's probably going to die, if not from the heart attack, then pretty soon from the cancer or whatever it is anyway. In which case, might as well have a DNR, a do not resuscitate order. Okay? So this is widely seen as legal everywhere. All right. Now, physician assistance in dying, I'll write it again, physician assistance in dying is more controversial. This is, again, remember, allowing doctors to give lethal or life-ending drugs to patients. Okay? In the United States, this is legal in a handful of states. In the US, it's legal in, I think, Oregon was the first one, Washington State was second, Montana, New Mexico, Vermont, California. Okay, now my data is a little bit old. I just checked Wikipedia, I think like 2 years ago, maybe 3 years ago. Maybe some states have legalized it since then. There are activists just about all through the country always pushing to get this legalized in every state. I guarantee, for example, that New Jersey has a group of activists who's trying to get, some PAD legalization passed in New Jersey. All right. Internationally, it's still not that popular. Legal in Switzerland, Germany, Japan, Albania, of all places. Okay. Incidentally, also, I'll put this as a kind of sub-bullet, I just want to point out that the scope of the problem we're talking about here is tiny, especially compared to I think the previous problem one of the previous problems we talked about, which was animals. So in Oregon, in 2014, where Oregon was the first state, where PAD was legalized, I think over 30 years ago now. In Oregon in 2014, 155 people requested life-ending drugs. Okay, and 105 people used them. Okay, among the people who used them were people who requested them in previous years. So it's not as if, 2/3 roughly of the people who request them end up using them. I think the fraction is actually less, like it ends up being less than half. But you can see, compared especially to our unit on animals, this is, relatively speaking, a tiny, 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 tiny problem. This is not like 9 billion. This is like hundreds. Maybe you could creep into the thousands through the whole country. Maybe. Okay? All right. What about active euthanasia? Active euthanasia is illegal in the US, everywhere, in every state. Okay? But it is legal in certain other countries. Let's see, let me scroll down to my list here. I cannot find this. I'm going to pause and look at my list. Oh, okay, got it. But legal in the Netherlands, this is the most famous one and the first place to make this legal. Belgium, so these kind of northern European countries. Ireland, Colombia somehow, Luxembourg. Luxembourg. Okay? All right. There are stories of people trying to move to places where either PAD or active euthanasia, which remember, these two things we're going to just lump together and call these both the right to die. And remember, the right to die does not include passive euthanasia because passive euthanasia is already seen as, just totally fine. Okay. But there are stories of people who move to places with the right to die because wherever they happen to live, when they get some, fatal illness and they're in a lot of pain, it's not legal where they live, so they move to these other places. And that's kind of a sad but poignant story when that has to happen. Okay. All right, I think that's all I wanted to talk about for context. So let's move on and talk about the Rachel's arguments. So now we're going to focus on James Rachel's, and the title of his article is Passive and Active Euthanasia. Okay, one of the homework assignments that I asked you to do is to write down in one sentence or so what his thesis is. And this one, I think, it's pretty clear. Okay, so his thesis is basically this. Active euthanasia is no worse than passive euthanasia. Okay? And the implication of this is, if passive euthanasia is fine, or I won't even put it as if then, I'll put it as because passive euthanasia is fine, we all think it's totally not a big deal, so also is active euthanasia. Active euthanasia is fine too. Okay? That's going to be what he tries to argue. All right. Now his article is really dense in that I think it's only, what, like 3 pages that I asked you to read? But in those 3 pages, you can find 4 different arguments. 3 kind of positive arguments for this thesis, and then 1 response to an objection. All right, so let's go over some of the positive arguments. And the first argument is what I sometimes call the more humane argument. The more humane argument. Okay? And the argument goes something like this. It says, we use passive euthanasia in order to be humane. You know, to not, and being humane here means being, making someone comfortable, better off, when they can't live through whatever, they can't live through whatever is killing them. Okay? So, you've heard this word used, the Humane Society or something, and this is like, Humane Society would be a shelter for animals, like dogs and cats that have been abandoned, and you're, again, trying to be nice to them. All right, so here, Rachel's points out that sometimes we use passive euthanasia, which again, everyone agrees is okay, in order to be humane to people who are otherwise going to die and be in a lot of pain. Okay? And so he gives this example. Someone dying of throat cancer. Okay, so he says someone dying of throat cancer can be very painful. They can't swallow, they can't eat, they lose a lot of weight. All right, they cannot talk sometimes. Okay, they lose like their vocal cords. All right, it can be a very miserable experience. All right, I think this is what killed Roger Ebert, the film critic. I think it was either throat cancer or something in his neck. But anyway, it can be a very miserable and painful experience at the end when it's incurable. You can be in a lot of pain and nothing can relieve the pain. All right. So what might happen in this case is, in order to be humane, we might engage in passive euthanasia, where this person with throat cancer might not have any infection, their heart might be totally fine, they might not ever have any other thing that's going to kill them quickly. It's just that throat cancer would have them linger and they would die within a few months from the throat cancer. So instead, we might hasten their death with passive euthanasia in the form of withholding food and water. Okay? So basically, you stop feeding the person and you stop giving him water. And then so the person will die within a few days from the lack of water. Okay? So here are the options then. Option number 1, in this case, I'm going into a little bit more detail than what Rachel's mentions in his article. So, read through the article, but be sure that you're clear on what he actually says and what I say. Don't misattribute things like in your papers, either to me or to him. Okay, so option number 1 would be aggressive measures, but still die from throat cancer in 6 months. Okay, that would be option 1. Option number 2 would be withhold food and water. Instead of aggressive measures and chemotherapy and all that and lots of agony that entails, and dying of throat cancer anyway in 6 months, withhold food and water, die within, say, 1 week, okay, from dehydration. All right, so Rachel says, look, option 2 is certainly better than option 1. All right, option 1, aggressive measures, but you're going to be in a lot of pain, you can't control the pain, you're going to die anyway in 6 months. That's a tough way to live, especially, if someone doesn't want to live that way. Option 2 is absolutely better. Die within a week from withholding food and water. But Rachel says, why not option number 3, which is, huge dose of morphine, or today they might use fentanyl, okay, and then die within minutes. All right. So Rachels basically says, James Rachels, he says, option number two is preferable to option number one because 2 is more humane than 1. 2 treats the person better. The person is not in as much pain. They end their suffering more quickly, right? So then he says, but 3 is preferable to 2 for the exact same reason. For the exact same reason that 3 is more humane than 2, okay? So he says, look, our goal in this case is to be humane. That's why we moved from option 1 to option 2. We wanted to be humane, to be nice, okay? But once we have committed to being humane, why not move to option 3, which is even more humane than option number 2, all right? And I think he mentions in the article how, like for doctors and family members, option 1 is terrible to go through and terrible to watch if you're a doctor and a family member, but also, so is option number 2. It's terrible to watch and terrible to go through when these people like just refuse food and water and they just suffer and die. They linger on and get more and more dehydrated. You know, that's an uncomfortable way to die. Why not just give them one last blast of morphine or fentanyl, make them feel good, and then they die within minutes? Okay, so that's the first argument, where he says active euthanasia, at least sometimes, is better than passive, because the whole motivation for passive euthanasia was to be humane, and it turns out sometimes active euthanasia is even more humane than passive is. All right, that's the first argument. Second argument, sometimes I call this irrelevant criteria. Okay. This is kind of a weird argument. I don't want to spend too much time on it because I think it's neither the most straightforward argument, that was the first one that we just mentioned, nor the one that has gotten the most attention, which is the third one, the one that's coming up. This one is kind of the neglected stepchild argument. Everyone tends to ignore it. Okay, but here's his claim. He says distinguishing between active and passive euthanasia allows us to use irrelevant criteria to determine who lives and who dies. We shouldn't do that. Therefore, we shouldn't distinguish between active and passive euthanasia, okay? He gives kind of an interesting example here, and this is an example of a Down's syndrome baby who may or may not have an additional medical issue. So Down syndrome is obviously one issue a baby might have. The additional medical issue that the baby might or might not have is a blockage, or I'll just say intestinal blockage. That's not spelled right. Intestinal blockage. And the actual one that's most common for these babies with Down syndrome is duodenal atresia. The duodenum, or sometimes also pronounced duodenum, depending who you talk to, the duodenum or the duodenum is the first bit of your small intestine right after the stomach. Okay, atresia means basically it didn't grow properly and didn't open properly. So the stomach and your intestines are supposed to form a tube from your mouth to your butthole, and that's what you use to digest food. Your food goes through this very long tube. Okay. What atresia does is sometimes babies are born where the tube does not actually have a hole in it. It's kind of stuck. So it's clogged, basically. It's like it didn't open all the way and make an actual tube, okay? And that happens more often in babies with Down syndrome than it does in healthy babies, in babies without Down syndrome. All right. It does happen just randomly to lots of babies, but it happens more often. It's more likely to happen if the baby also has Down syndrome. All right. So here's what would happen in the 1970s when Rachels was writing. His article is a classic, so I still assign it today, even though it's like 50 years old now, or 45 years old now. So this doesn't happen anymore, but in the 1970s when Rachels was writing, this did happen, okay? So if parents had a Down's syndrome baby they didn't want, okay? But the baby was otherwise healthy. They were stuck, with the baby, okay? So not every parent wants to raise a kid with Down syndrome, all right? But if the baby was otherwise healthy, the doctors in the hospital would say, sorry, just tough luck, here's your baby, go home, okay. On the other hand, if the baby, Down syndrome baby also had the duodenal atresia, then doctors would offer to not fix the atresia. Okay? They would say, hey, your baby with Down syndrome also happens to have this other disease, duodenal atresia. Let's just not fix it. Okay, and then what happens is the baby cannot eat, or the baby will eat, but then will start vomiting because nothing can go through that tube because it's blocked right there. So the baby will become more and more malnourished and eventually will starve to death no matter how much you try to feed it. Okay? And in that case, the baby will die, and die pretty quickly within, days or so. And then, yay, parents who didn't want the Down syndrome baby don't have to go home with it. Okay? In contrast, an otherwise healthy baby with duodenal atresia is automatically fixed. The surgery to fix duodenal atresia is very simple, very straightforward. I'm not even sure if it requires general anesthesia. I think you can just go through the mouth, just basically stick like a tube down the baby's mouth, and like once you get to the blockage, the tube could have a little instrument in it or something. You can just, poke open the blockage, and so you make the tube open again. All right, so it's a very simple procedure, very not risk-free, but very low risk. All right, very cheap and very quick to do. All right, an otherwise healthy baby, in other words, one without Down syndrome, with this other problem, duodenal atresia, it's just automatically fixed. Otherwise, it's considered, malpractice. Okay, like a family that has a healthy baby with duodenal atresia, if the doctors say, you know what, we don't want to fix the duodenal atresia, they could be sued big time for not wanting to fix the duodenal atresia. But in the 1970s, they couldn't be, or they weren't, if the baby also had Down syndrome. All right, so again, this doesn't happen anymore for Down syndrome babies. They don't kind of offer this other option of like, hey, if your Down syndrome baby also has this other issue, we just won't fix this other issue. That doesn't happen anymore. But in the 1970s, it did. All right, and so his point was as follows. He said, JR for James Rachel's, he said, this is deciding which baby lives based on irrelevant criteria. Okay, the relevant criteria, relevant criterion, singular, is Down syndrome. Okay, Down syndrome is the thing that makes the parents not want to go home with the kid. The duodenal atresia is irrelevant because the duodenal atresia is so easy to fix. So the relevant criterion is Down syndrome. The irrelevant criterion is duodenal atresia. Okay, and Rachel says these doctors and these family members are using the irrelevant criteria, duodenal atresia, to decide which Down syndrome baby lives. He thinks that's a horrible practice, just to say, hey, these Down syndrome babies who happen to have this other issue, duodenal atresia, we can let them die, but we would never take a Down syndrome baby who doesn't have duodenal atresia and like say smother its face with a pillow. We would never do that to kill another Down syndrome baby. He thinks this is just hypocritical, and so that's another reason why we should not distinguish between passive and active euthanasia, all right? Because even though it's passive euthanasia to just not fix the duodenal atresia, and it would be active if you smothered an otherwise healthy Down syndrome baby, he thinks like this is just a double standard, hypocrisy. All right, so that's the irrelevant criteria argument. Okay, now the third argument, which is the one that I think has gotten the most pushback from Rachel's critics, killing versus letting die. So remember, I've already said this, active euthanasia is a form of killing. Okay, and passive euthanasia is a form of letting die. A form of rather than identical to. It's not identical to, because there's certain, you can kill people without it being active euthanasia. Like murder is not active euthanasia. Remember, euthanasia is, the whole goal of euthanasia is to be good to the person who's dying. It's supposed to be a good death for the person who's dying. So murder is not a form of euthanasia, it's just killing. But, so in other words, killing is the broader umbrella category, and active euthanasia is the more narrow category that fits totally within the killing category. And then similarly for passive euthanasia, being the narrower category that fits totally within the larger umbrella category of letting die. Okay, but Rachel's wants to say, JR wants to say, killing is no worse than letting die. Morally, they are morally equivalent. Maybe I'll put it that way. Killing is morally equivalent to letting die. Okay? And this is something that, if you remember when we talked about charity, Narveson addresses this thesis. Narveson, when he claims killing is not morally equivalent to letting die. Killing someone, like by starving him to death, is worse than not rescuing someone who already was starving through no fault of your own. Okay? So Narveson discusses this very conclusion that Rachel's is coming to. All right, how does Rachel's get to this conclusion? Well, he says, here's an example. He wants to give us an example where one example or one story is killing, the other story is letting die, one story of killing, one story of letting die, Everything else is the same. And he wants to show that if we hold everything else the same, then I'll make it as a conditional. If everything else is the same, then the two stories are morally equivalent. The people in the stories are equally immoral or equally bad or good. All right? So here are the two stories that he tells. This is a very famous story. A lot of people in the philosophical literature have commented on it or written about it. Okay? So there's Smith and Jones. Smith and Jones are, just generic names for people who often appear in philosophy examples. Okay? So I guess maybe before I tell the story of Smith and Jones, so this is what they have in common. Okay? They both are, I think, cousins to a 6-year-old, to a rich 6-year-old. Okay? Both stand to gain a huge inheritance if the 6-year-old dies. Both, okay? And then both go up to the tub where the 6-year-old is bathing, intending to drown him, intending to drown the 6-year-old in order to get this inheritance. All right, so they're both walking up there, they're both entering the bathroom. Okay, here's where they differ, where they come apart. Smith actually drowns the kid. Okay, Jones, even though he intended to drown him, he had the plan, he's walking up there, he sees the kid bathing, notices the kid is already drowning, and merely refuses to rescue him. Okay? Also, just to make this clear in case it wasn't, if the kid were to, survive, then Jones would drown him. He would if the kid somehow was able to fight and get his head above water, then Jones would put his hand down and push his head back under the water. Okay? Then Jones would drown him, but it turns out this isn't necessary. Okay? This little parenthetical aside is just to prove, because I've gotten some papers that misunderstand this, just to prove that Jones has exactly the same intention as Smith. He's prepared to do exactly the same thing Smith is doing. Okay? But it just turns out it's not necessary. It's not necessary. All right. Now Rachel's asks, JR asks, who is worse, Smith or Jones? So Smith actually drowns the kid. This is a killing, right? He kills the kid. So Jones, instead, merely lets the kid die. This is a letting die. Okay. Who is worse, Smith or Jones? Rachel suggests, and maybe you'll agree with him, neither. They're equally bad. Okay? They're equally bad even though Smith actually killed the kid and Jones merely neglected to rescue a kid who was already dying. Okay. So if that's right, if Rachel's is right that they are equally bad, then Rachel says, well, that means killing and letting die are equally bad, because he tries to fix every other possible difference between these two cases so that the only difference, the so-called bare difference between them, is whether an actual killing takes place versus a letting die. So these two cases, these two people are equally bad, okay? Therefore, killing and letting die are equally bad, okay? And so therefore, like, the mere fact that active euthanasia is a form of killing does not make it worse than passive euthanasia, which is a form of letting die. All right, so that's the third argument. Okay, so last thing in Rachel's before we go is he considers an objection. So response to an objection. So, you know, Rachel's, he was writing this like 45 years ago, but he would give talks with this topic to different doctors and other medical groups, and he heard the same kind of objection over and over again, okay, from doctors when they would come up and talk to him after his presentation, okay? And so the objection goes like this. The objection goes, an important difference between active and passive euthanasia is that in passive euthanasia, the doctor isn't doing anything. So something else caused the death. You know, for example, heart attack, okay, or pneumonia, okay? In contrast, in active euthanasia, the cause of death is the doctor, okay? So in particular, like on the death certificate, when they ask for cause of death, okay, in passive euthanasia, you may write, you know, heart attack, okay? But in active euthanasia, you must write something like, you know, me injecting morphine or whatever it is, okay? Okay, so that's the objection he got. So lots of doctors said, hey, your arguments sound compelling. We are maybe potentially persuaded, but there is this hitch, there's a problem. How do I fill out the death certificate? If I kill this person, I have to fill out the death certificate honestly and say I was a killer. Whereas for passive euthanasia, I don't have to say that. I can just mention pneumonia, okay? Okay, so Rachel's has a few responses to this. So first he says, the doctor does something even in cases of letting die, okay? Analogously, he says, I might insult you by not shaking your hand, okay? If I refuse to shake your hand, that might still be an insult. And if I let you die, I'm still doing something that might be wrong, okay? No, not morphine. In cases of letting die, I might be doing something that's still wrong. For example, if you go back to the Down syndrome case, all right? So consider a healthy baby with duodenal atresia. A healthy baby with duodenal atresia, if the doctor says, you know what, I refuse to fix your baby's duodenal atresia, I'm going to go home and play golf instead, that doctor could be sued, okay, because that doctor did something wrong by not fixing the duodenal atresia, all right? So basically, Rachel's wants to say, you can be culpable, you know, blameworthy for not doing something you should have done, okay? Okay. Another thing he says is, JR, also, fixing cause of death is important for legal reasons, but it's not relevant to the ethics of euthanasia. So it just doesn't address his arguments for how morally it is better sometimes to kill, to be quick about it, than to let someone linger and die. Okay. And then 3, lastly, even if the law recognizes the difference between active and passive euthanasia, that just means we need to change the law. Okay, so he says, don't hide behind the law to say what's good or bad. His whole point in giving this talk is try to change the law. And we've seen that the law, at least for physician assistance in dying, has changed over the last few decades. More and more states are allowing physician assistance in dying. I think Canada just legalized it last year, I think. Okay, So that's it on Rachel's and his defense of active euthanasia. Thanks.